Hi, I'm Nicola. Welcome to Hampshire and Isle of Wight Air Ambulance. This is the HEMS base at Thruxton. Today you're going to hear from Nigel, the pilot, who will show you around the helicopter. Then we'll speak to Vic, one of our doctors, who will take you through the critical care car. And then later you'll speak to Fran and Julian, who will take you through a simulation in our sim suite.
Hi, my name's Nigel and I'm one of the pilots that flies here with Hampshire and Isle of Wight Air Ambulance Charity. First thing I do when I come in the morning, apart from turning the lights on obviously, is I'm going to do a fuel check in the aircraft. Why do I do that? It's because I can check the fuel is nice and clear and it hasn't got any water in it basically. Before I take the aircraft out, I'm going to do a quick walk around of it and close some of the cowlings so they're out of the way so I don't need to worry about doing it outside, and just give it a quick once over and a visual inspection of it. Just checking the fenestrons to make sure there's not too much play in the blades. So on this side, what I'm doing is actually looking inside this cowling here and checking the level of the oil in the tail rotor gearbox. Good, that's the aircraft ready to go outside now, which will allow me to do the engine wash, which we do daily, to check the compressor blades and make sure the engine works at its maximum efficiency. And then also allows me to do a check of all the systems on the aircraft.
Hampshire Radio, good morning. Telemetry start, ground run only, one on board, 3 in attendance. Okay, starting number 1, engine first, it's an update.
As you'll imagine, front right seat, that's where I sit and do my business. In the back here, you'll see we've got 2 seats, forward facing and rear facing, and a stretcher. This is where either a doctor and a paramedic sit, or a passenger can sit anyway in the back here. In the front left seat, the technical crew member sits. A technical crew member is a paramedic or a doctor who's been trained as a crewman as well, so they can assist me in the front with map reading, emergencies, using the radios, etc. This seat here is a very clever seat because it allows us to swivel it round if we need to. Now the reason we can swivel the seat round is to allow us to do, the paramedics to do airway management for a patient in the back if necessary. We can either load through the side door here, like this, or in the rear doors.
Hello, I'm Nicola. I'm a paramedic as part of the critical care team. This is the blood. We received this from the blood transfusion team at Southampton Hospital. And in here we've got fresh frozen plasma and blood products. In here is our primary response bag. This is where we keep all of our immediate equipment that we need when we first approach a patient. This is our secondary response bag, and in here is all of the extended skills that we use when we respond to patients who are critically injured. In here is the ventilator that's used when people receive a pre-hospital emergency anaesthetic. Let's go around to the back and I'll show you the other kit. Here is our Lucas device. This helps us do hands-free CPR. This is our paediatric bag. As part of the critical care team, we also respond to children who are critically injured or unwell. This bag contains 2 syringe drivers. This is often used when taking patients a long way from hospital to hospital and advanced skills have been carried out. This is our spares bag. The ability for us to be able to restock whilst at hospital before returning to base is essential, meaning that we can go straight from one mission to another. This bag contains our vacuum splints for people who require assistance when they have broken a limb. So this is the equipment that the critical care team carry. As you can see, the equipment with the team with advanced skills helps us to bring the hospital to the patient.
Thanks very much for coming around and visiting us today, and more importantly, thanks very much for all your support throughout the year.
Hi, my name is Vic Renberg. I'm one of the air ambulance doctors here with Hampshire and Isle of Wight Air Ambulance. I also work as an anaesthetist at Southampton Hospital. Let me show you what kit we have in the back of this car. So we carry a range of specialist life-saving equipment on the car to complement the ambulance service. We have blood in our bags here, which comes with a warming device so that we can deliver warmed blood to the patient. So we carry them in specialist cooling boxes so that we can keep the blood fresh for as long as possible until it gets to the patient and needs to be used. In the red bag, we have the immediate life-saving equipment we will need for the majority of our patients, and that will go to any job that we go to. In our black bag, we have extra equipment that we need, for example, when patients have major hemorrhage or if they need to be put onto a ventilator, and the additional equipment we will need for those particular patients. We also have our life support machine, our ventilator for patients with severe respiratory problems or who are unconscious. We carry specialist pediatric equipment for children. We also carry an automated chest compression device for patients in cardiac arrest, as well as specialist defibrillators that allow us to correct abnormal heart rhythms, as well as additional spare equipment and immobilization equipment, and of course oxygen that we might need for our patients. Okay, come this way and we'll look in the front of the car. So our vehicles are equipped with navigation equipment to help us get to any patient as quick as possible. When we are tasked on a job, it will come up on the sat nav here and it will navigate us automatically to where the patient is. And this is our radio that allows us to keep in touch with the emergency dispatch centre and the ambulance teams on scene. In addition to our navigation and communication equipment, these vehicles are extremely high performance and very, very safe, that allow us to get to the patient as quickly as possible, but also as safely as possible. It's a big day for me. First time I got to do the sirens. The car allows us to respond whatever the weather, so even if the weather's not good enough for us to fly in the helicopter, we can still reach our patients when they need us the most. So we get called out on average 4 times a day between the aircraft and the car, depending on weather conditions. We have 3 cars here at Hampshire and Isle of Wight Air Ambulance. We have 2 Skodas and a Volvo that help us to respond whatever the weather. Thanks very much for joining us and having a look around the car, and thanks very much again for your support.
Hi, I'm Frances. I'm one of the HEMS doctors at the Hampshire and Isle of Wight Air Ambulance, and today we're going to show you our simulation suite. This is where we train on a daily basis, performing skills and interventions that are required to patients of a critical nature. We're going to demonstrate a simulation of a road traffic accident and the kind of interventions that we can bring to the patient at the roadside. We can bring the ventilator and blood to the patient pre-hospitally, which will improve their outcome in the long term.
So Fran, we've come to this motorcyclist. It looks like he's fallen off his motorbike and his helmet's come off already.
Yeah.
I can't see any massive hemorrhage, can you?
No, it looks safe to approach, so let's go in. I'll get in and assess his airway first of all. So, hello sir, can you hear me? Okay, so he's not really responding there to me. He's not opening his eyes. I'm just inflicting some response, so he's not opening his eyes. He is groaning and is extending. Yeah. Okay, so we've got about a GCS of 1, 2, 3, so GCS of 6. Okay. He's got a little bit of snoring there, so can I get an oropharyngeal airway? So we're just going to pop this in. This is going to support his airway temporarily while we do a further assessment. Just going to pop this into your mouth, sir. There we go. So he's tolerating that well, and we'll pop some oxygen on, so that we'll fill that bag up and pop that over his mask.
While you're doing that, Fran, I'm just going to put some monitoring on.
Yeah, that would be great, and I'll continue to do his primary survey. There we go,
I'm just going to expose his chest.
Right, let's pop this out of the way. I'll come around this side. This is bad. Okay, so I've had a look at his airway, so breathing. Right, he's got bilateral chest movements there. I'll have a little feel. There's no obvious deformities or crepitus on his chest.
Nope.
Blood pressure.
So that's just cycling for you. We'll get that up in a moment.
Good, so we've got some saturation, so I'm feeling for a radial pulse there, which will tell me in the meantime that he's got reasonable blood pressure, and he's got a good blood pressure there.
Lovely.
Right, I noticed some bruising on the right upper part of his tummy, so that might indicate some internal injuries, in particular to his liver. Feels nice and soft, doesn't appear to be grimacing with pain. And now we've got our blood pressure. So his blood pressure is 103 systolic, which is a little bit low for this gentleman, and his heart rate is fast at 127.
Okay.
So if you're happy to get some intravenous access.
Yeah.
Right. Julian, I think we should put a pelvic binder on this patient. The mechanism of him coming from his motorcycle is a high risk for a pelvic injury. With a pelvic fracture, you can lose the whole volume of your body's blood into the pelvis. So the purpose of the pelvic binder is to try and compress that injury and reduce the blood loss.
Lovely.
So
I'll come round and
put that on now.
Let's do it.
Okay, so if we just pop this under his legs, I'll
Yep.
speed it through to you.
Lovely, I've got it.
Okay, and then we'll just
Wiggle
move
it
that
up.
gently up, being careful not to move him too much.
Lovely.
So I'm just feeling for the level of his greater trochanters.
Yep.
Okay, I'm happy with that level now. So if we bring that together, one end for you. So this device is called a T-pod, and then we can pull it together, which pulls any parts of the broken pelvis together. So this brings the two halves of the pelvis together and then reduces any blood loss the patient may have from a pelvic fracture. So it's what we call a rapid sequence induction, and that basically means that we use drugs to quickly put him into an induced coma and paralyse him, and that allows us to put a breathing tube and carefully control his breathing for him. Okay, so I'm going to switch that over to what we call a bag valve mask. All right, so just going to put a mask on your face. So he is breathing for himself, but I can, with his breath, just support his breathing to make sure that we have optimal conditions. The reason for this is we want a person with a head injury not to have low oxygen levels, as that can have consequences in their recovery.
Yep, so laryngoscope, we're going to use a video laryngoscope because this patient looks like they might have a more difficult airway.
Yeah, we need to protect his cervical spine because he's had a trauma, so we don't want to move his neck at all.
Yep, we've got a bougie, we've got our tube, which is a size 7, and it's cuffed and lubed. We have our filter mount and end-tidal CO2 and our BVM. Rescue ventilation, we will use an iGel, a size 5 for this gentleman. Yeah. We've got our surgical airway pack, should we need it.
Yeah.
Fentanyl dose.
So I estimate this gentleman's 90 milligrams, so we'll go a 1-to-1 regime.
Yeah.
So fentanyl 90, ketamine 90 and rocuronium 90.
Sounds good. Intubating clinician.
This is myself.
Assistant, that will be me. Plan A.
If you can do some mid-inline mobilisation,
Yeah.
and I will use a bougie and the video laryngoscope and the size 7 tube as planned.
Plan B will be an iGel and Plan C will be a front of neck.
Yeah, he's easy to ventilate, so I think the iGel should be adequate.
Excellent. Okay, so I'm happy to push the drugs now.
So a patient should now be anaesthetised and paralysed.
Just timing 60 seconds on my watch, starting now.
You have those, and if you do the inline immobilisation.
Okay, so here's your video, here's your bougie. I'm doing inline immobilisation.
Okay, so that's to prevent me inadvertently moving the neck, which could cause injury to his spine.
Yeah.
Okay, so the minute has passed.
Yeah.
The patient is paralysed, he's not making any respiratory effort, so I'm happy that we go ahead. Okay, I'm going to remove this. Thank you. Okay, so I'm using the video scope to get the best view first time. So I've got a grade 1 view of the cords. I'm inserting the bougie And the bougie has passed through the cord. The bougie allowed us to get access in between the vocal cords, which you can see on the screen there. And now you're passing the intubation
so I've got
tube.
the bougie.
Okay, I'm placing the tube, and we can watch the tube pass through the cords there. I'm happy that that's between the cords, so you can remove the bougie. Okay, and if you can attach.
I'm just going to put the cuff up.
Yep, and if you then attach the bag valve mask.
So this
Okay,
is
so I'm
now
happy there, that's
attached.
good. And we can ventilate the patient.
So as we're ventilating, I can see end-tidal CO2, I can see misting of the tube, I can see chest rise and fall equal on both sides.
Yep.
I'm just going to get my stethoscope out and have a listen. And then once we've confirmed placement, we'll tie the tube off.
Yep.
All right. So if you just do a breath for me there. Yeah, good air entry. Good air entry.
Great.
And no air entry,
Wonderful.
which is good for the esophagus.
Okay, so let's secure that. We can reassess the patient, ensure that they're still stable, and then I think at that point we can move the patient towards transporting the patient to hospital.
Yeah.
So I think from our location, the best option is to fly the patient, because this is a time critical need for the patient to get to hospital and potentially need operating theatre. And in the back of the aircraft we can put him on our ventilator machine, and I think we should take him to the major trauma centre with his injuries, which our closest would be Southampton.
Perfect, sounds good.
Great, thank you.
As you can see in some of these patients with critical injuries, they might not make it to hospital before getting interventions. The idea of our critical care team is to bring the hospital to the patient where they can receive life-saving treatment. Some of these interventions that we do, the ambulance service isn't able to offer, and so we're able to add these things to the pre-hospital care so that patients that we see have a better chance of survival and a better chance of going home and having a good neurological outcome. Lastly, we would like to say thank you to you. It's thanks to your donations that we're able to run this service. It's not inexpensive to have a doctor, a paramedic and a pilot provide this service to patients, and without you we wouldn't be able to do this. You're the reason that we're able to run our service and to see these patients and help them as best we can, so thank you very much.